Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. Imagine a microscopic breach. Just this tiny millimeter-wide erosion in the mucosal lining of your stomach. On a Tuesday, it's just, a dull ache.
Right.
But fast forward 48 hours, and because of that one tiny breach, your blood pressure has completely plummeted, your kidneys have just stopped filtering, your blood has become dangerously acidic, and, your brain is being starved of oxygen.
Yeah.
You are in multi-organ failure. And it all started with a spot in your stomach the size of a pinhead.
It's a terrifying scenario, honestly. But it's a perfect illustration of how the body actually works. I mean, we like to think of our organs as these independent contractors, right? Like the stomach does its job, the kidneys do theirs.
Like they're in their own little silos.
Exactly. But the reality is the human body is this tightly wound, incredibly sensitive network. A localized failure is, it's almost never just a localized failure.
And that interconnectedness, that massive, terrifying, awe-inspiring cascade of events is exactly what we're plunging into today. So welcome to another deep dive brought to you by the Last Minute Lecture team.
Absolutely.
Whether you are prepping for a clinical rotation or maybe studying for an advanced pathophysiology exam, or you're just, insanely curious about the machinery keeping you alive, you are in the right place. We are your one-on-one tutors today, and our mission is to decode the human gastrointestinal system.
And to do that successfully, we really have to establish a golden rule for how we approach this material, because we are not going to just memorize lists of symptoms.
No, it's definitely not.
Memorization is fragile, It vanishes the second you walk out of an exam, or worse, step away from a patient's bed. So instead, we're going to rely on strict logical flow.
Right, because pathophysiology is really just a story of cause and effect.
Exactly. If you understand the normal, healthy physiology of a system, you will naturally understand what happens when cellular function is altered. And that altered cellular function leads to tissue and organ dysfunction.
Which then leads directly to the symptoms.
Right, inevitably to the clinical signs and symptoms you actually see at the bedside. If you understand the fueling mechanism, the symptom list basically writes itself.
So let's lay out the playing field before things start going wrong. When we talk about the GI system, we are essentially talking about one continuous hollow tube.
Yeah, a very long tube.
Right. It starts at the mouth, goes down the esophagus, expands into the stomach, winds through roughly, 20 feet of small intestine.
It's give or take.
Transitions into the large intestine or colon, and finally ends at the rectum and anus.
But that tube doesn't act alone. It is heavily supported by accessory organs of digestion. So we're talking about the salivary glands, the liver, the gallbladder, and the pancreas.
Yeah.
These organs sit outside the tube, but they dump their vital enzymes, bile, and buffers into the lumen to make digestion even possible.
And we're going to explore what happens when things break down, starting with the broadest warning signs your body gives you, and then we'll drill down into specific structural and organ failures. So let's start with the alarm bells.
The general clinical manifestations.
Yeah, the big non-specific ones.
Right.
Anorexia, nausea, retching, and vomiting.
And we use the word non-specific very deliberately here. Take anorexia. In a pathophysiological context, we aren't talking about the psychiatric eating disorder.
Right, that's a common confusion.
Yeah, we are talking about the purely physiological lack of desire to eat, despite having the physical stimuli that should make you hungry. I mean, your stomach is empty, your blood sugar is dropping, but you have zero appetite.
Which is incredibly frustrating diagnostically, isn't it? Because if a patient says, I have no appetite and I'm a little nauseous, they haven't narrowed anything down.
Not at all.
That could be heart failure, it could be uremia from kidney disease, a systemic infection, or literally just immense psychological stress.
Precisely. It is a generalized systemic response. But vomiting or emesis is a completely different story. Emesis is highly specific, and the mechanics of it are fascinating.
It's so violent.
It really is. It's the involuntary, forceful emptying of the stomach and intestinal contents, which we call chyme up and out through the mouth. And what is most wild about this highly physical, gut-wrenching action is that the command center for it isn't in your stomach at all.
It's in the brain, which feels so counterintuitive until you trace the wiring.
Yeah, the vomiting center is located deep in the brainstem, in the medulla oblongata, specifically in a region called the area postrema.
The area postrema.
Right. Think of the area postrema as the ultimate emergency override switch. And this switch can be thrown in two distinct ways, indirectly or directly.
Let's walk through the indirect route first, because I think this is the one most of us have experienced. Say you eat something tainted, maybe some questionable seafood. How does the brain actually know what's in the stomach?
Well, your gut is lined with spiralized surveillance cells called enterochromaffin cells.
Okay.
When these cells detect a toxin or severe irritation, they immediately release serotonin, specifically 5-hydroxytryptamine or 5-HT.
So serotonin is acting as the local alarm bell down in the gut.
Yes, exactly.
Yep.
That serotonin binds to receptors on the vagal afferent nerves. These are the sensory highways that run from your gut all the way up your neck and into your brain.
Oh, yeah.
And the vagus nerve carries this panic signal straight to a specific spot near the area postrema called the chemoreceptor trigger zone, or the CTZ.
And the CTZ is like, what, the bouncer outside the vomiting center?
It is. That's a great way to put it. The CTZ is packed with receptors for serotonin, dopamine, and opioids. It samples the blood and the cerebrospinal fluid.
So it's constantly monitoring.
Right. And when the CTZ receives that massive serotonin signal from the vagus nerve, it turns to the vomiting center and basically says, we have a critical poison situation. Initiate purge.
But the gut isn't the only thing that talks to that bouncer, right?
Yeah.
Like if I get motion sickness on a boat, it's not because of my stomach.
No, not at all.
It's because the vestibular system in my inner ear is getting conflicting signals about my body's position in space. And that vestibular system sends a signal through the 8th cranial nerve directly to the vomiting center.
Exactly. And if you are in excruciating pain or experiencing sheer terror, your cerebral cortex and thalamus can send signals that trigger vomiting too. It's an incredibly integrated defense mechanism.
Okay, so that's indirect. The signals are coming from the periphery. What about direct stimulation?
So direct stimulation bypasses all the surveillance systems and physically provokes the vomiting center itself. Imagine a patient with a rapidly growing brain tumor or someone who just suffered a severe head trauma that resulted in increased intracranial pressure.
Oh, I see where this is going.
Yeah, the physical swelling of the brain tissue physically presses down on the medulla oblongata.
It's literally squeezing the trigger.
Exactly. And clinically, this looks very different. Indirect vomiting is usually preceded by nausea, sweating, tachycardia, retching.
You feel it coming.
Right. But direct stimulation of the vomiting center causes sudden, spontaneous projectile vomiting. There is no warning, no nausea, just an explosive expulsion.
Wow.
That is a massive red flag for a neurological emergency, not a GI bug.
That distinction is so critical. And, we really have to talk about the physical toll this takes on the body. Because vomiting isn't just unpleasant, it is metabolically violent.
It is a massive pressure event. To vomit, you take a deep inspiration, your glottis closes to protect your airway, and your abdominal muscles contract with incredible force. This drives the diaphragm high up into the thoracic cavity.
You're creating this massive pressure gradient.
Yeah.
And then the door at the top of the stomach, the lower esophageal sphincter relaxes, the stomach forcefully spasms, and the chyme is violently pushed up the esophagus.
And if you do this repeatedly, the metabolic consequences are severe. I mean, you aren't just losing water, you are losing massive amounts of sodium, potassium, and chloride.
Electrolytes just gone.
Right. This leads to hyponatremia, hypokalemia, and hypochloremia. Furthermore, because stomach fluid is packed with hydrochloric acid, vomiting it out means you are losing a huge amount of acid from your body.
Which throws off the pH balance.
Exactly. The remaining blood becomes highly alkaline.
So severe prolonged vomiting throws you into metabolic alkalosis alongside massive dehydration and electrolyte derangement. It really is a full system crisis.
It is. Now let's shift our focus to the other end of the motility spectrum, constipation. This is a term patients use casually all the time to describe feeling bloated or maybe not having a bowel movement for a day. But in a clinical setting, we have to demand precision.
I actually love how rigid the criteria are for this because it takes the guesswork out of it entirely. Yeah. You can't just diagnose primary chronic constipation based on vibes. You use the Rome-5 criteria, which is basically a highly specific checklist.
And that checklist forces you to look at the actual mechanics of the dysfunction. Primary chronic constipation usually falls into 3 categories. You have functional defecation disorders, where the pelvic floor muscles simply aren't coordinating properly to allow evacuation.
Okay.
You have slow transit constipation, where the neural motor activity of the colon itself is impaired. The waves just aren't moving the stool along. And you have irritable bowel syndrome with constipation or IBS-C.
So if a patient comes in, according to the Rome 5 criteria, they need to have been experiencing at least 2 specific symptoms for the last 3 months. It's not just about infrequency, though, right? I mean, having fewer than 3 bowel movements a week is on the list, but it's more than that.
It's heavily about the effort and the quality of the stool. Are they straining during at least 25% of their bowel movements? Is the stool lumpy or hard a quarter of the time?
Right.
Do they have a persistent sensation of incomplete emptying or a feeling that there is a literal anorectal blockage? Some patients even have to resort to manual maneuvers using their fingers to facilitate evacuation.
If they meet those criteria, we're looking at primary chronic constipation. But we also have to be medical detectives and rule out secondary constipation. Because sometimes the gut is perfectly healthy, but it's being held hostage by something else entirely.
Neurogenic disorders are a massive culprit here. Parkinson's disease, multiple sclerosis, or spinal cord injuries can sever or scramble the neural pathways that dictate colon transit time.
The signals just don't get there.
Right. If the brain can't talk to the gut stops moving.
And we have to talk about medications, too. Opioids are famous for this.
Oh, they are. The gut has a vast network of mu-opioid receptors. When a patient takes an opiate for pain, those drugs don't just act on the brain. They bind to the receptors in the gut wall, drastically inhibiting peristalsis.
It just shuts it down.
Yeah, the transit time grinds to a halt. The colon extracts more and more water from the stationary stool, and it becomes like concrete.
Okay, let's flip the coin. Diarrhea. This isn't just one problem either. The symptom is loose, watery stool, but the pathophysiological mechanism behind it tells you exactly what's failing. There are 3 major mechanisms, right? Osmotic, secretory, and motility.
Exactly. Let's break those down. Osmotic diarrhea is entirely about concentration gradients. Water naturally wants to move toward areas with a high concentration of solids. So imagine you ingest a substance that your intestine absolutely cannot absorb.
Like a synthetic sugar substitute, like sorbitol. Or maybe you have a lactase deficiency and drink a big glass of milk. You literally can't break down that lactose.
Right. That unabsorbed substance sits in the intestinal lumen and acts like a powerful magnet. It draws massive amounts of excess water out of the intestinal wall and into the lumen via osmosis.
Wow.
The sheer volume of water overwhelms the colon's ability to reabsorb it, and you get large volume watery diarrhea.
But the diagnostic clue here is pretty simple. If you stop eating the offending substance, the diarrhea stops. The magnet is gone.
Now contrast that with secretory diarrhea. This is not passive. This is active biological warfare.
Biological warfare.
Yeah. This is often driven by an infectious pathogen. Take Vibrio cholerae or the exotoxins produced by Clostridioides difficile.
Ugh, C. diff is an absolute nightmare.
It really is. These pathogens release toxins that directly attack the enteroendocrine cells lining your mucosa. They hijack the cellular machinery, triggering an excessive, uncontrolled secretion of chloride and bicarbonate-rich fluid right into the gut lumen.
While also stopping sodium absorption, right?
Exactly. They actively inhibit the absorption of sodium.
So your intestinal wall is actively pumping your own plasma water into your gut cavity. It's a massive fluid loss, and it doesn't stop just because you stop eating. You have to actually kill the pathogen or bind the toxin.
And the third mechanism is motility diarrhea. This is simply a failure of time.
Right, because digestion and absorption require contact time. The chyme has to sit against the intestinal wall long enough for the nutrients and water to be pulled across.
If a patient has had a surgical resection of their small intestine, a condition known as short bowel syndrome, they physically lack the square footage for absorption.
The food just rushes through.
Right. It moves through the shortened tract far too rapidly. There's no time for water reabsorption, resulting in constant, debilitating diarrhea.
And wrapping around almost all of these conditions is a symptom that brings patients into the emergency room more than almost anything else: abdominal pain.
Assessing abdominal pain is an art form, honestly. Because the patient usually just says, my stomach hurts, but we have to map that pain to distinct neural pathways to understand what is actually failing. We categorize it into parietal, visceral, and referred pain.
Okay, let's start with parietal or somatic pain.
Parietal pain originates from the parietal peritoneum, which is the membrane lining the entire abdominal cavity. The nerve fibers here are A delta fibers, and they travel alongside your somatic peripheral nerves.
And somatic nerves are the same ones that let you feel a pinprick on your finger, right? They are highly organized.
Exactly. Because of that specific wiring, parietal pain is intense, sharp, and brilliantly localized. A patient with parietal pain can often point with one single finger exactly to the spot that hurts. It might lateralize perfectly to one side.
Got it. Pinpoint and sharp. What about visceral pain? Because this one is always trickier to pin down.
Visceral pain arises directly from the organs themselves, the stomach, the gallbladder, the intestines. Now, the nerve endings within these organs are relatively sparse, and they don't respond to cutting or burning.
Like, really?
Yeah, you could cut an intestine and not feel it the same way. They respond to massive stretching, distension, or severe inflammation.
It's more of a blunt force alarm.
Yes. And cruelly, the sensory afferent nerves from these organs enter the spinal cord bilaterally on both sides, and they are multi-segmented.
So it's confusing the brain.
Because the signal is coming in from so many scattered pathways, the brain simply cannot pinpoint the location.
So instead of a sharp, localized pain, the patient feels a diffuse, vague, dull, aching, or cramping sensation. They'll just kind of rub their whole midsection and say, it kind of hurts everywhere right here.
Exactly. It's radiating and poorly localized, often accompanied by feelings of fullness or a gnawing sensation, and the biochemical mediators setting off these nerve endings are the classic drivers of inflammation: histamine, bradykinin, and serotonin.
Oh, sure.
As the organ swells, it stretches the capsule, releasing these chemicals, triggering the visceral pain response.
Which brings us to referred pain, which I think is just one of the coolest physiological quirks we have.
It is a literal wiring glitch in the human body. Referred pain is visceral pain, pain from an organ that is felt at a completely different, distant location on the surface of the body.
But how does the brain get it so wrong?
It happens because the deep diseased organ and the distant patch of skin share a central afferent nerve pathway into the spinal cord. They basically share the same extension cord plugged into the central nervous system.
I love that extension cord analogy.
Yeah, so when the intense pain signal travels up from the organ, the brain misinterprets the origin and projects the sensation onto the skin dermatome.
And the absolute classic example of this is acute cholecystitis, right?
Yeah.
An inflamed gallbladder. The patient comes in, their gallbladder is massively inflamed under their liver, but they are complaining of intense pain in their right shoulder or right scapula.
Exactly.
A brain is feeling the shoulder, but a fire is in the abdomen.
It is a critical diagnostic clue. Now, we need to transition to a manifestation that requires immediate aggressive intervention: gastrointestinal bleeding.
Yeah, this is where a manageable problem turns into a life and death crisis. We look at this anatomically to start. We basically divide the tract in half. An upper GI bleed is anything occurring in the esophagus, the stomach, or the duodenum.
We're talking about bleeding from esophageal varices, which we will definitely get to later, or a violently bleeding peptic ulcer, or maybe a tear in the junction between the esophagus and stomach, known as a Mallory-Weiss tear.
Right. And a lower GI bleed is anything below that, from the jejunum all the way down through the ileum, the colon, and the rectum. This could be bleeding from polyps, inflammatory bowel disease, diverticulitis, or hemorrhoids.
The vocabulary we use to describe the blood itself tells us where it's coming from and how fast it's bleeding. Hematemesis is the vomiting of blood.
Okay.
If it is bright, fresh red, the bleed is active and likely in the esophagus or upper stomach.
But what if it looks like dark, grainy coffee grounds?
That means the blood has been sitting in the stomach long enough for the hydrochloric acid to partially digest it. It's still an upper bleed, but it might be slower. Then we have melena. This is black, sticky, tarry, incredibly foul-smelling stool.
That's a very specific description. Why is it tarry and black?
Because the blood originated high up in the GI tract and has journeyed all the way through the intestines. As it travels, the digestive enzymes and gut bacteria break down the hemoglobin into dark pigments. Melena is proof that digestion of blood has occurred.
Hematochezia, on the other hand, is the passage of fresh, bright red blood from the rectum. This usually indicates a lower GI bleed, right? The blood hasn't had time to be digested because it's bleeding right near the exit.
Precisely. And we cannot forget occult bleeding. Occult means hidden. This is trace amounts of blood in perfectly normal appearing stool.
So you can't even see it.
No, you cannot see it with the naked eye. You have to use a chemical assay like a guaiac test to actually find it.
Why is occult bleeding so dangerous if it's just a tiny amount of blood?
Because it is slow, chronic, and silent. A slow-bleeding colon polyp can leak trace amounts of blood for months or years. The patient has absolutely no idea until they present to their doctor with severe, unexplained iron deficiency anemia.
Wow.
Their red blood cell count is bottomed out because they've been bleeding a few drops a day for a year.
Okay, that covers the slow bleeds. Let's look at a catastrophic, acute, massive GI bleed. I want to trace the absolute cascade of shock. This is the physiological nightmare I mentioned at the very top of the show.
Let's trace it step by step. Yeah. Let's say a massive ulcer ruptures an artery in your stomach. You are rapidly losing whole blood volume directly into your gut lumen.
Immediately, my total blood volume drops. Because there's less fluid in the pipes, my blood pressure plummets.
Right. Your cardiac output, the amount of blood your heart can pump per minute, drops significantly. Your systolic blood pressure falls below 100 millimeter Hg. Your body's baroreceptors sense this massive drop in pressure, and the autonomic nervous system panics.
It initiates a massive compensatory response. My heart rate spikes tachycardia trying to pump whatever blood is left faster, and my peripheral arteries clamp down tight.
That peripheral vasoconstriction is a triage mechanism. The body realizes it doesn't have enough blood to supply everything, so it sacrifices the periphery to save the core.
It's prioritizing.
Exactly. It shunts blood away from your skin, your gut, and your skeletal muscles to try and maintain flow to the brain and the heart.
But it doesn't just sacrifice the skin. I want to really dig into this because this is where the interconnectedness is just so brutal. Why does a stomach bleed cause my kidneys to fail?
Because the kidneys are part of that sacrificed periphery. Right. The body constricts the renal arteries to keep blood in the central circulation, so the blood flow to the kidneys drops drastically.
So the kidneys are starving for oxygen.
Exactly. When renal perfusion drops, the kidneys cannot filter the blood. Your urine output falls drastically, oliguria. If this ischemia, this lack of oxygen, lasts for too long, the delicate tubular cells in the kidneys begin to actually die. This is acute tubular necrosis.
The kidney tissue is dying. And once it dies, it stops filtering toxins and regulating pH.
Yes. Without the kidneys actively filtering acids out into the urine, metabolic acidosis sets in. The blood becomes dangerously acidic. But the cascade doesn't stop there.
Because the rest of the body is also starving for oxygen.
Right. Because of the massive blood loss, oxygen delivery to all your tissues is profoundly compromised. Without oxygen, your cells can't perform normal aerobic metabolism.
So they switch pathways.
They switch to anaerobic metabolism, which is incredibly inefficient and produces a highly toxic byproduct, lactic acid.
So now I have my kidneys failing to clear acid and undin my cells massively dumping new lactic acid into the blood. Lactic acidosis compounds the metabolic acidosis.
Exactly. The pH of your blood plummets. This highly acidic environment impairs cellular function everywhere. Eventually, this lack of oxygen and acidic environment reaches the brain.
The brain anoxia.
You experience brain anoxia, leading to confusion, stupor, a deep coma, and ultimately, if the blood volume isn't rapidly restored, death.
A ruptured artery in the stomach. It destroys the kidneys, poisons the blood, and starves the brain. It is just a stunning cascade of dominoes.
And it highlights exactly why aggressive fluid and blood resuscitation is the absolute priority in GI bleeds. You have to break the shock cascade before the tubular necrosis becomes irreversible.
Wow. Let's take a breath, step back from the brink of multi-organ failure, and look at structural issues. We're moving into disorders of motility, starting at the top of the tube with dysphagia, which is simply difficulty swallowing.
Dysphagia broadly falls into two categories: mechanical obstruction and functional obstruction. Mechanical is exactly what it sounds like. There's a physical barrier.
Okay.
It could be an intrinsic obstruction, like a tumor growing inside the esophageal wall, or maybe a stricture from scar tissue. Or it could be extrinsic, a tumor in the surrounding tissue physically pressing against the outside of the esophagus, pinching it closed.
It's like stepping on a garden hose. The water just can't get through. But functional dysphagia is wilder, I think. The tube is completely clear, structurally perfect, but the machinery moving the food is broken.
This brings us to a rare but fascinating disorder called achalasia. To understand achalasia, you really have to understand normal swallowing. It's not just gravity dropping food into your stomach.
No, it's an active process.
It is a highly coordinated wave of muscular contraction governed by a neural network called the myenteric plexus, which is embedded in the esophageal wall.
And crucially, as the wave pushes the food down, the lower esophageal sphincter, the ileus, the door to the stomach has to receive a signal to relax and open.
In achalasia, the patient suffers an autoimmune response that specifically targets and destroys the inhibitory neurons within that myenteric plexus.
The neurons that say relax.
Exactly. Without those inhibitory neurons, the lower esophageal sphincter loses its ability to relax when you swallow. The resting muscle tone remains high.
So the door at the bottom of the esophagus just stays locked tight no matter how hard you swallow.
Imagine what that feels like. You eat a piece of chicken. It goes down the esophagus and hits a locked door. You eat more, drink some water. The esophagus physically distends and balloons out just above the stomach. The hydrostatic pressure of the trapped food builds and builds until the sheer physical weight of it slowly, painfully forces small amounts past the sphincter.
It must be excruciating and incredibly dangerous because if that trapped food backs up, it can spill over into the trachea, causing aspiration pneumonia.
Very dangerous. Now, if achalasia is the door being locked shut, our next disorder is the door swinging wide open when it shouldn't. GERD, or gastroesophageal reflux disease.
This is a classic. In a healthy person, the resting tone of that lower esophageal sphincter is about 15 to 25 millimeter Hg. It creates a high-pressure zone that keeps the highly acidic stomach contents right where they belong.
But in GERD, that sphincter tone weakens, or it experiences transient, spontaneous relaxations when it shouldn't.
So the door swings open, and stomach acid sneaks up into the esophagus. Now, the stomach is lined with thick, protective mucus to handle a pH of 2, but the esophagus is not.
The esophageal mucosa is highly vulnerable. When that acidic refluxate washes over it, it causes severe mucosal injury. It triggers hyperemia, increased blood flow, and redness.
Right.
It causes increased capillary permeability, leading to massive tissue edema or swelling. And over time, it physically erodes the tissue, causing ulcerations. The patient feels this as intense heartburn or retrosternal chest pain.
But we really have to make a clinical distinction here because not all esophageal inflammation is caused by acid. Let's talk about eosinophilic esophagitis, or EOE.
This is a condition that has seen a massive rise in diagnoses over the past few decades. A patient comes in with classic GERD symptoms, dysphagia, chest pain, food impaction. You might assume it's just acid reflux.
But how does the cellular mechanism of EOE differ from standard GERD?
The difference is night and day. EOE is not fundamentally a plumbing issue or an acid issue. It is an idiopathic, chronic, allergic, or immune response. If you scope a patient with GERD and take a biopsy, you see chemical acid erosion.
And if you biopsy an EOE patient,
you see a massive infiltration of eosinophils.
Interesting.
Yeah, eosinophils are a type of white blood cell primarily associated with fighting parasites and driving allergic reactions. In EOE, the esophageal lining is packed with them. The body is essentially mounting a severe allergic reaction within the esophageal wall itself, leading to intense inflammation, fibrosis, and eventual narrowing of the tube.
Which is why EOE is heavily correlated with atopic individuals, people who also suffer from asthma, eczema, or severe food allergies. Treating it with antacids won't fix the underlying immune hyperresponse. You often have to use topical steroids or aggressive elimination diets.
Absolutely. Let's stick with the esophagus and look at another structural failure. Hiatal hernias. A hernia is generally defined as the protrusion of an organ into a space it does not belong. In this case, the stomach is pushing its way up through the diaphragm into the thoracic cavity.
Right, the diaphragm is the muscle separating the chest from the abdomen. The esophagus passes through a small hole in it called the diaphragmatic hiatus to reach the stomach. But sometimes things get pushed upward.
We classify these hernias largely into 3 types. Type 1 is the sliding hiatal hernia, and it's the most common. In a sliding hernia, the proximal portion of the stomach, the very top part, and the gastroesophageal junction essentially slides straight up through that hiatus into the chest cavity.
It's like the stomach is riding an elevator up into the chest.
Yeah.
And this is heavily influenced by posture, right?
Yes. When the patient lies down flat, gravity no longer keeps the stomach anchored in the abdomen, and it slides up, often causing severe acid reflux. When the patient stands back up, gravity often pulls the stomach back down into its proper position.
Okay, that's type 1. What about type 2? This is the rolling or paraesophageal hiatal hernia.
The geometry here is totally different. In a type 2 hernia, the gastroesophageal junction stays perfectly anchored right where it should be, below the diaphragm. But a secondary defect or opening forms in the diaphragm right next to the esophagus.
And a portion of the stomach, usually the greater curvature, bulges up through that secondary hole, so it's sitting up in the chest right alongside the esophagus.
And type 2 hernias are incredibly dangerous. Because the stomach is squeezing through a tight, fixed muscular ring in the diaphragm, that pocket of stomach can become trapped.
Which leads to strangulation. Let's unpack the pathophysiology of strangulation. Why is that an absolute surgical emergency?
When that pouch of stomach gets trapped and pinched tightly by the diaphragm, the venous blood can't drain out of it. The tissue becomes engorged and edematous. As it swells, the pressure increases until it cuts off the arterial blood supply as well.
Total ischemia. The tissue is completely deprived of oxygen.
Exactly. Without blood flow, that entire section of the stomach will quickly undergo necrosis. It will die, become gangrenous, and potentially perforate, spilling stomach contents right into the chest cavity. It is rapidly fatal without intervention.
And just to complete the set, a type 3 mixed hiatal hernia is exactly what it sounds like, a combination of both the sliding and the rolling mechanisms occurring simultaneously.
Now, let's follow the tube deeper into the abdomen and look at what happens when the main pathway of the small intestine is blocked: intestinal obstruction and ileus.
Let's look at the mechanical blockades first. How do you physically block a 20-foot tube? You have herniation, where a loop of intestine pushes through a weakness in the abdominal wall and gets pinched off.
You have adhesions, which are actually the most common cause of small bowel obstructions. Adhesions are fibrous bands of scar tissue. Every time you have abdominal surgery or severe abdominal inflammation, the body lays down fibrin to heal.
Okay.
Sometimes these fibrin bands form permanent tight ropes that wrap around loops of intestine, literally tying them in knots or crimping them shut over years.
Wow. You also have volvulus, which is a violent torsion. The intestine physically twists around its own mesenteric pedicle, the stalk of tissue that anchors it and supplies its blood. It twists like a wet towel, cutting off its own lumen and its blood supply simultaneously.
And intussusception. This is more common in infants but happens in adults too. This is where a segment of the intestine telescopes inside an adjacent segment. Think of pushing the tip of a glove finger inward on itself.
That's a great visual.
It drags the mesentery in with it, compressing the blood vessels and blocking the flow of time.
But here is the most important takeaway about intestinal obstructions. Regardless of how the tube is blocked, whether it's a scar tissue rope, a twisted stalk, or a tumor, the pathophysiological cascade that follows is universal, and it is brutal.
Let's trace this obstruction cascade meticulously because it is a race against time. Imagine the tube is completely blocked. What happens immediately proximal to meaning just before the obstruction?
Well, the chyme has nowhere to go. And the digestive system is constantly pumping in massive amounts of fluid, saliva, gastric juice, bile, and pancreatic enzymes, so fluid rapidly begins to pool. And the resident bacteria continue to ferment whatever food is there, producing massive amounts of gas.
So you have massive gas and fluid sequestration. The intestine directly above the blockage begins to severely distend. It balloons outward.
It's exactly like overinflating a cheap rubber balloon. You keep blowing air in, the rubber stretches tighter and tighter, it turns white, and eventually the structural integrity just fails.
That is a phenomenal analogy. That severe physical distension causes two massive physiological crises. First, the mechanical problem. The massively swollen intestine pushes aggressively upward against the diaphragm,
which compromises respiratory volume. The lungs can't expand fully, leading to atelectasis, collapsed alveoli, and pneumonia.
But the second crisis is the local tissue disaster. As the intestine inflates like that balloon, the intraluminal wall tension skyrockets. The tissue is stretched so thin, so tight, that it physically compresses the veins embedded in the bowel wall.
Wow.
Venous return stops. The wall swells with trapped blood.
And as the pressure continues to rise, it overcomes arterial pressure as well. The arteries are pinched shut. Arterial blood flow ceases. The bowel wall is now completely ischemic. The tissue is literally suffocating.
The tissue begins to die. And as it dies, the mucosal barrier, the cellular shield that keeps everything inside the gut, fails completely. Capillary permeability goes through the roof.
Massive amounts of plasma fluid leak directly out of the necrotic bowel wall and dump into the peritoneal cavity. This rapid third spacing of fluid pulls volume right out of your vascular system, leading straight to massive hypovolemic shock.
But the terror doesn't stop with fluid loss. Remember, the gut is filled with trillions of bacteria. Because the barrier is now dead and permeable, those bacteria rapidly translocate.
They escape?
They cross the necrotic wall, enter the sterile peritoneal cavity, and dump massive amounts of bacterial endotoxins into the body.
So now the patient has severe peritonitis, massive systemic inflammatory response, fever, and remote organ failure. The cardiovascular system collapses. What started as a mechanical blockage of a tube has become a rapid descent into fatal hypovolemic and septic shock.
It is the ultimate example of why GI pathophysiology demands respect. A local problem rapidly becomes a systemic catastrophe.
Okay, let's move out of the small intestine and look at the stomach itself. We are diving into gastritis and peptic ulcer disease. Gastritis is simply inflammation of the gastric mucosa.
We divide this clinically into acute and chronic. Acute gastritis is usually superficial. The stomach has a thick mucosal barrier to protect it from its own acid. If you injure that barrier, you get acute gastritis.
And the most common culprits here are NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen or naproxen and alcohol. I want to explain exactly how NSAIDs cause this damage, because it's a brilliant piece of pharmacology causing a terrible side effect.
It comes down to a group of lipid compounds called prostaglandins.
Right. Prostaglandins are essentially the guardians of the stomach lining. They maintain the mucosal blood flow, and critically, they stimulate the epithelial cells to secrete the protective mucus layer and the bicarbonate that neutralizes acid at the surface.
But how do NSAIDs work to stop your headache or joint pain? They inhibit an enzyme called cyclooxygenase, or COX. EOX is required to synthesize prostaglandins.
I see.
So by blocking COX, NSAIDs stop the prostaglandins that cause pain and inflammation in your knee, but they also systemically wipe out the protective prostaglandins in your stomach.
Without prostaglandins, the mucus layer thins out. The bicarbonate secretion drops, the stomach's defense shield is lowered, and the harsh hydrochloric acid just burns right into the superficial mucosa, causing acute inflammation and bleeding.
Alcohol acts a bit differently. It causes direct chemical damage to the epithelial layer, disrupting the lipid barrier and allowing acid to back diffuse into the tissue.
Now, what about chronic gastritis? Because this is a longer, slower burn that actually leads to the atrophy and loss of the gastric glands themselves.
Chronic gastritis is generally classified into type A, which is immune or fungal gastritis, and type B, which is non-immune or antral gastritis. Type A is relatively rare, but the mechanism is fascinating. It is an autoimmune disease. Your own T cells lose tolerance and develop autoantibodies that specifically attack and destroy the acid-secreting parietal cells in the stomach.
And parietal cells don't just secrete hydrochloric acid, they also secrete intrinsic factor.
Exactly. Intrinsic factor is a glycoprotein absolutely essential for the absorption of vitamin B12 later on in the small intestine. If you destroy the parietal cells, you lose intrinsic factor.
And without B12?
Without B12, you cannot synthesize healthy red blood cells, leading directly to a condition called pernicious anemia.
But while autoimmune type A is interesting, the undisputed king of gastritis and peptic ulcer disease is a bacteria called Helicobacter pylori.
H. pylori is a marvel of evolutionary biology. It is the primary driver of type B chronic gastritis and the vast majority of peptic ulcers.
But we have to pause here. The stomach is a hostile environment. It has a pH of roughly 1.5 to 2. It is a vat of hydrochloric acid designed to dissolve dense proteins. How can a fragile, single-celled bacteria survive, let alone thrive and colonize, in a literal acid bath?
It survives because it has evolved a highly specific toolkit to neutralize that environment. Let's break down its arsenal. First, it has flagella, multiple tiny whip-like tails.
Oh, to move around?
Yes. The moment H. pylori enters the stomach, it uses these flagella to rapidly swim out of the highly acidic lumen and burrow deep down into the viscous protective mucus layer where the pH is slightly more hospitable.
Okay, so it hides in the mucus, but it's still surrounded by acid. How does it protect itself?
This is its masterpiece. H. pylori secretes an enzyme called urease. Urease takes urea, which is naturally present in the stomach, and aggressively breaks it down into carbon dioxide and ammonia.
And ammonia is highly alkaline. It is a powerful base.
Precisely. By constantly pumping out urease, the bacteria surrounds itself in a microscopic cloud of alkaline ammonia. It literally neutralizes the hydrochloric acid in its immediate vicinity. It builds its own personalized pH-neutral force field so the acid can't touch it.
That is incredible and terrifying. Because once it's safe inside its force field, it goes on the offensive against the stomach lining.
It anchors itself to the epithelial cells and releases an array of destructive toxins. One key toxin is VAC-A, or vacuolating cytotoxin A, which directly induces apoptosis or cell death in the epithelial cells.
It also injects a protein called CAG-A directly into the host cells. CAG-A is notorious because it completely disrupts the host cell's cytoskeleton and triggers a massive release of inflammatory cytokines, specifically TNF-alpha, interleukin-1, and interleukin-6.
This massive cytokine storm acts like a beacon, calling in neutrophils and macrophages. The resulting severe inflammatory response further degrades the mucosal barrier.
It just strips it away.
Exactly. Between the toxins and the inflammation, the barrier is stripped away, allowing the stomach acid to rush in and utterly destroy the deep tissue, creating a crater.
Which brings us to peptic ulcer disease, or PUD. The tissue is dead, a crater has formed. We need to contrast the two main locations this happens: gastric ulcers in the stomach and duodenal ulcers in the upper small intestine, because they present very differently to the clinician.
Duodenal ulcers are far more common. They typically affect a younger demographic, usually patients between 20 and 50 years old. The hallmark clinical sign of a duodenal ulcer is a very specific pain pattern: pain antacid relief or pain food relief.
Why does eating food make a duodenal ulcer feel better?
Because when you eat, the food physical acts as a buffer. It mixes with the stomach acid, raising the pH temporarily before the chyme empties into the duodenum. So when the stomach empties the buffered food over the ulcer, it doesn't burn as badly.
Oh, that makes sense.
However, they frequently wake up in the middle of the night in excruciating pain because the stomach is empty and pure. Unbuffered acid is washing over the duodenal crater.
Gastric ulcers, on the other hand, usually affect an older demographic, often between 55 and 65 years old, and their pain pattern is the exact opposite. The pain occurs immediately after eating.
Because the physical act of eating stimulates the stomach to ramp up acid production. That fresh surge of unbuffered acid washes directly over the ulcer in the stomach wall, causing intense, immediate pain.
Because eating equates to pain, these patients develop severe anorexia. They refuse to eat, leading to significant unintended weight loss, which is a major clinical red flag.
Let's trace the pathophysiological cascade of a gastric ulcer forming. It is a vicious cycle of destruction. It starts with that damaged mucosal barrier, whether the damage was initiated by H. pylori, chronic NSAI use, or the reflux of bile salts from the duodenum back into the stomach.
Once that barrier is broken, you get the back diffusion of hydrogen ions acid directly deep into the gastric mucosa. The acid burns the cells, but it also triggers a secondary disaster. It causes the local conversion of pepsinogen into pepsin.
Pepsin is a proteolytic enzyme. It digests protein. When it activates deep in the tissue, it accelerates the erosion, literally digesting the mucosal cells and destroying the capillary beds, which causes the bleeding.
But the tissue doesn't just sit there. The massive cell damage liberates huge intracellular stores of histamine.
And histamine is a nightmare in this context. Histamine binds to H2 receptors on the parietal cells, powerfully stimulating them to secrete even more acid, fueling the fire.
But histamine also does what it does everywhere else in the body. It causes massive local vasodilation and a drastic increase in capillary permeability.
The blood vessels in the stomach wall open up and leak fluid. The tissue swells drastically, mucosal edema, and you begin to lose massive amounts of plasma proteins straight out of the bloodstream and into the gastric lumen.
And as if that wasn't enough, the acidic environment overstimulates the cholinergic intramural nerve plexus, causing severe cramping muscle spasms in the stomach wall. It is a complete multi-tiered collapse of the stomach's structural integrity.
Let's move further down the tract. We are entering the small intestine, which is the primary site of nutrient absorption. We need to discuss malabsorption syndromes.
And the very first thing we have to do is separate two terms that are constantly confused, but represent fundamentally different physiological failures: maldigestion and malabsorption.
Maldigestion is a chemical failure occurring entirely within the lumen of the gut. You eat a complex protein or fat, and you simply lack the necessary digestive enzymes to break that large molecule down into its basic absorbable building blocks, amino acids, or fatty acids.
So the food remains chemically locked.
Exactly. Malabsorption, however, is a structural failure of the intestinal mucosa itself. In malabsorption, the enzymes worked perfectly. The food was chemically broken down into tiny, perfect building blocks.
But they can't cross over.
Right. The intestinal villi, the transport proteins, or the lymphatic vessels are damaged. The mucosa fails to physically pull those nutrients across the barrier and into the bloodstream.
They frequently occur together, but the root cause requires different interventions. Let's look at three highly specific syndromes that illustrate this perfectly. First, pancreatic exocrine insufficiency.
The pancreas is a factory that produces the most vital digestive enzymes: lipase to break down fat, amylase to break down carbohydrates, and trypsin and chymotrypsin to break down proteins.
If the pancreas is severely damaged, say by chronic recurrent pancreatitis or a genetic disease like cystic fibrosis, the factory shuts down. You lose these enzymes.
The most immediate and clinically profound deficit is the lack of pancreatic lipase. Without lipase, you experience severe fat maldigestion. The fat you eat cannot be broken down.
Because the fat remains intact, it cannot be absorbed. It passes straight through the entire tract, resulting in a hallmark symptom, steatorrhea. These are large volume, pale, incredibly foul-smelling, fatty or greasy stools.
But steatorrhea is just the messy symptom. The systemic danger is what goes missing. If you can't absorb fat, you also cannot absorb any fat-soluble vitamins.
Exactly. Vitamins A, D, E, and K require lipid absorption to enter the body. The systemic consequences of losing these are massive. A lack of vitamin A leads to night blindness. A lack of vitamin D halts calcium absorption, leading to severe bone demineralization, osteoporosis, and bone pain.
And vitamin K.
A lack of vitamin K stops the liver from synthesizing prothrombin, leading to a prolonged prothrombin time, purpura, and severe bleeding disorders.
All because the pancreatic factory stopped making one enzyme. Okay, second syndrome, lactase deficiency. This is incredibly common worldwide.
This is the lack of a highly specific enzyme called lactase, which normally resides right on the brush border, the microscopic microvilli of the small intestine. Lactase's only job is to break down lactose, the complex sugar found in mammalian milk, into simple galactose and glucose.
If you lack lactase, either genetically or due to mucosal injury, that lactose sugar remains completely intact in the lumen.
And this triggers a dual crisis. First, the intact lactose continues down into the colon, where billions of bacteria are waiting. They violently ferment the sugar, producing massive amounts of gas, which causes severe bloating, cramping, and flatulence.
And second, it acts just like the sorbitol we talked about earlier. It creates a powerful osmotic gradient. The undigested lactose draws massive amounts of water out of the intestinal wall into the lumen, resulting in explosive, high-volume osmotic diarrhea.
Third syndrome, bile salt deficiency. This is a fascinating mechanism. Bile salts are synthesized in the liver from cholesterol and stored in the gallbladder. I always use a kitchen analogy for this. Bile salts are the dish soap of the gut.
That is the perfect way to visualize it.
If you cook bacon and try to wash the greasy pan with just hot water, nothing happens. The fat is hydrophobic, it repels the water, it just clumps together in a big slick. But the second you add a single drop of dish soap, the grease instantly shatters into millions of tiny, manageable droplets that mix with the water and wash away.
That chemical shattering is called emulsification. In the gut, bile salts do exactly what the dish soap does. They are amphipathic, they have a water-loving side and a fat-loving side. They surround the large fat globules and shatter them into tiny microscopic spheres called micelles.
Why are micelles so important?
Because the brush border of the intestinal villi is covered by an unstirred water layer. The fat has to cross that water to be absorbed. Without the bile salts forming the micelles, the fat remains a massive, insoluble globule that simply bounces off the water layer and continues down the tract.
So if you have severe liver disease or a gallstone completely blocking the bile duct, you have no bile salts in the gut. The fat can't form micelles. You get identical symptoms to pancreatic insufficiency, profound steatorrhea, and severe deficiencies in vitamins A, D, E, and K. But the root cause wasn't a lack of enzymes, it was a lack of the biological dish soap.
Let's shift away from malabsorption and look at diseases defined by profound chronic inflammation. We need to discuss inflammatory bowel disease, or IBD. This primarily encompasses two distinct giants, ulcerative colitis and Crohn's disease.
These are both devastating, chronic, relapsing autoimmune diseases. The body's immune system fundamentally loses tolerance to the normal, harmless flora of the bacteria living in the gut, and it mounts a massive sustained attack on the intestinal tissue. But they behave so differently.
Let's paint the comparative picture because the distinctions are critical for diagnosis and surgical planning. Let's start with ulcerative colitis, or UC. UC is a disease of continuous ascent. It almost universally begins in the rectum and marches continuously upward into the colon.
Continuous is the key word. There are no healthy patches left behind. It is a solid, unbroken sheet of fiery inflammation. But while it's broad, it is shallow.
Exactly. The autoimmune attack in UC is confined exclusively to the mucosal layer, the innermost lining of the colon. It does not dig deep into the muscular layers.
The mucosa becomes intensely hyperemic, dark red, and velvety. It becomes so friable, so fragile, that just the passage of stool causes it to bleed continuously. And as the mucosa tries to heal and regenerate in this toxic environment, it forms these erratic, inflammatory outcroppings called pseudopolyps.
Because the entire colon is inflamed, it completely loses its primary function, the absorption of water. The hallmark presentation of severe fulminant ulcerative colitis is frequent, urgent bloody diarrhea. A patient in a severe flare might experience 10 to 20 bloody bowel movements a day, leading to severe dehydration, profound anemia, and extreme pain.
Now, contrast that superficial continuous burn of UC with Crohn's disease. Crohn's does not follow any rules.
None. While UC is confined to the colon, Crohn's disease can aggressively attack literally any part of the gastrointestinal tract from the mouth to the anus. However, it most commonly strikes the distal small intestine, the terminal ileum, and the proximal colon.
And its pattern of attack is maddeningly discontinuous. You will look at a section of bowel and see a deep, violent, inflamed ulceration sitting directly next to a patch of perfectly healthy, pristine tissue. We call these skip lesions.
But the most devastating difference is the depth of the injury. UC is shallow. Crohn's is transmural. The inflammatory infiltrate the macrophages and T cells doesn't stop at the mucosa. It burns like a crater all the way through the submucosa, the muscularis, and the serosa, the entire thickness of the intestinal wall.
Think about what that means structurally. Because the inflammation goes all the way through, the wall becomes thick, rigid, and rubbery. This transmural scarring causes severe strictures, narrowing the lumen so much that it can cause complete mechanical bowel obstruction.
The deep ulcers also create fissures that look like deep knife cuts. And because the inflammation burns all the way through, it can create fistulas.
Fistulas are horrifying. They are abnormal inflammatory tunnels that connect the diseased bowel to entirely different organs. A tunnel might form from the intestine directly into the bladder or into the vagina or straight out to the skin of the abdomen, leaking bowel contents.
Furthermore, the immune response in Crohn's leads to the formation of non-case-eating granulomas, hard nodules of immune cells. The combination of deep fissures and raised granulomas gives the inner lining of the bowel a very classic, bumpy, cobblestone appearance.
And metabolically, because Crohn's so heavily targets the small intestine, severe malabsorption of nutrients, folic acid and vitamin B12, along with dramatic weight loss, are much more prominent features than in UC.
We have a few more intestinal disorders to cover before we move to the accessory organs. Let's look at diverticular disease.
To understand this, you have to picture the colon wall. It's not a perfectly uniform muscle. There are areas of relative weakness, particularly where small blood vessels penetrate the circular muscle layer to supply the mucosa.
If the intraluminal pressure in the colon is chronically high, often due to a low-fiber diet forcing the colon to contract violently to move small, hard stools, the mucosa can literally herniate or push outward, right through those weak points in the muscle wall.
These outward herniations form little pouches called diverticula. They're most commonly found in the left sigmoid colon in Western populations. If you just have the pouches sitting there quietly, you have diverticulosis. It's an asymptomatic structural change.
But if one of those narrow-necked pouches gets blocked by a piece of hardened stool or debris, it becomes a stagnant, trapped environment. The local bacteria proliferates wildly, causing acute inflammation and infection. Now you have diverticulitis.
The patient will present with significant pain, usually localized to the left lower quadrant, accompanied by fever and an elevated white blood cell count. And the absolute terror here is that the inflamed, fragile pouch will rupture, dumping massive amounts of colonic bacteria directly into the peritoneal cavity, causing life-threatening peritonitis.
Speaking of inflamed pouches, we must discuss appendicitis, which remains the most common surgical emergency of the abdomen.
The appendix is a small, blind-ended tube jutting off the cecum. The pathophysiology of appendicitis is, at its core, a simple closed-loop obstruction.
The tiny opening of the appendix gets blocked. In adults, this is usually caused by a fecalith, a hard calcified stone of stool. In children, it might be lymphoid hyperplasia, swollen lymph tissue from a recent viral infection.
Regardless of the cause, the exit is blocked. But the mucosal lining of the appendix doesn't know that. It continues to secrete mucus and fluids into the blind tube.
The fluid has nowhere to go. The intraluminal pressure inside the tiny appendix builds rapidly. This pressure stretches the walls and compresses the veins draining the organ. Venous engorgement leads to localized ischemia, which rapidly progresses to a massive inflammatory response.
And the clinical progression of the pain here is a masterclass in the nervous pathways we discussed earlier.
It is. Initially, the severe distension of the appendix triggers those sparse bilateral visceral nerve fibers. So the patient initially feels a vague, diffuse, dull pain centrally located around their belly button, the periumbilical area.
They often just think it's bad indigestion. But over the next few hours, the severe inflammation burns its way completely through the wall of the appendix. When the fire reaches the outside, it physically touches and irritates the parietal peritoneum lining the abdomen.
The instant the parietal peritoneum is irritated, those highly specific A-delta somatic fibers fire. The pain suddenly migrates and localizes intensely to the right lower quadrant. It shifts from a vague visceral ache to a sharp, pinpoint parietal agony.
And just like diverticulitis, the ischemia will eventually cause the appendix wall to necrose, gangrene to set in, and the organ to rupture, requiring emergent surgical washout of the abdomen.
Let's briefly cover one more catastrophic vascular event, mesenteric vascular insufficiency. This is exactly what it sounds like.
The gut has a massive blood supply, primarily from the superior and inferior mesenteric arteries. Mesenteric insufficiency is when that blood supply is occluded. It could be an acute embolism, a blood clot thrown from the heart that lodges in the artery, or it could be a profound drop in systemic blood pressure that starves the gut of flow.
The gut mucosa is arguably the most sensitive tissue in the entire body to ischemia. It cannot survive without constant, high-volume oxygen delivery. If blood flow stops, the mucosal membrane rapidly, almost instantly, alters its permeability.
It's an explosive failure. Massive amounts of fluid dumped directly from the engorged blood vessels straight into the bowel wall and the lumen. The patient experiences sudden, severe, out-of-proportion abdominal pain, followed rapidly by urgent, bloody diarrhea as the dead mucosa slews off. If surgical vascularization isn't achieved immediately, the bowel becomes gangrenous, leading to rapid hypovolemic shock and death.
We are now taking a major turn in our journey. We are leaving the hollow tube itself and moving to the vital accessory organs. Let's look at the common complications of liver disorders.
And here is the connective thread we have to hold on to. The liver is the metabolic powerhouse, the great chemical processing plant of the human body. Everything you absorb from your gut goes straight to the liver first. And whether the liver is being slowly destroyed by chronic alcohol abuse, a relentless hepatitis virus, or severe fat infiltration, a failing liver produces a very specific, terrifying set of systemic complications.
It doesn't matter what killed the liver cells. The resulting physiological collapse looks remarkably similar. And the primary mechanical engine driving almost all of these devastating complications is portal hypertension.
Let's visualize the portal system. The portal vein is a massive pipe that collects all the nutrient-rich deoxygenated blood from the entire gastrointestinal tract, the spleen, and the pancreas, and it delivers it straight into the liver to be filtered and processed. Normally, the liver is like a highly porous sponge. The blood flows through it easily, and the pressure in the portal vein is incredibly low, around 3 millimeter Hg.
But if the liver becomes chronically inflamed, the body tries to heal it by laying down scar tissue fibrosis. If that fibrosis is extensive, as in cirrhosis, the liver becomes hard and nodular.
It's like pouring concrete into that soft sponge.
Exactly. The concrete sets. The vast network of microscopic sinusoids is crushed by scar tissue. Now, when that massive volume of blood from the gut tries to enter the liver, it meets an impenetrable wall of resistance. The blood backs up.
And because it backs up, the hydrostatic pressure inside the portal vein skyrockets. It jumps from a peaceful 3 millimeter Hg to over 10 millimeter Hg, sometimes much higher. This is portal hypertension.
That high-pressure blood has to find a way back to the heart. It cannot go through the liver, so it seeks out alternate collateral pathways. It bypasses the liver entirely by forcing open, tiny, thin-walled collateral veins that connect the portal system to the systemic venous system.
These collateral veins were never designed to handle high-pressure, high-volume blood flow. They balloon outward, becoming massive, tortuous, distended vessels. We call these varices.
You see varices developing in the lower esophagus, in the upper stomach, and in the rectum, where they present as severe hemorrhoids.
The esophageal varices are the most terrifying. You have these fragile, massive, bulging veins sitting right under the mucosal surface of the esophagus. If the patient eats something sharp, or the pressure spikes too high, or acid erodes the tissue,
the varix ruptures. The patient experiences catastrophic, painless, life-threatening hematemesis, vomiting massive amounts of bright red blood. Because the liver is also failing and not producing clotting factors, the bleeding is incredibly difficult to stop. Ruptured esophageal varices have a staggeringly high mortality rate.
The next massive complication driven by portal hypertension is ascites. Ascites is the accumulation of fluid in the peritoneal cavity, the free space of the abdomen. And the pathophysiological cascade that causes this is a perfect storm of failure. It is not just one mechanism. It is the liver failing on multiple fronts simultaneously.
Let's trace the exact mechanism. Factor number 1 is that portal hypertension. The immense backup of hydrostatic pressure in the portal system physically forces water out of the mesenteric capillary beds and straight into the abdominal cavity. The pressure is so high that lymph fluid actually weeps directly off the surface of the hardened liver, dripping into the belly.
Factor number 2, Impaired synthesis. The hepatocytes, the liver cells, are dying. One of the liver's main jobs is synthesizing albumin, a massive protein that floats in your blood.
Albumin acts like a molecular sponge within your vascular system. It provides oncotic pressure, pulling water into the blood vessels and keeping it there. Because the liver is dying, it stops making albumin. Your blood albumin levels plummet. Without that pulling force, the water inside your blood vessels easily leaks out into the surrounding tissues, specifically the abdomen.
Factor number 3, vasodilation. The diseased liver and the collateral vessels release excess nitric oxide, which is a powerful vasodilator. This causes the splanchnic artery, the arteries feeding the gut, to massively dilate. Blood pools in the gut circulation, dropping the effective circulating blood volume in the rest of the body.
And this triggers factor number 4, the final blow. Your kidneys sense that drop in effective blood volume. The kidneys don't know the liver is failing, they just know the blood pressure is low. So they panic and activate the renin-angiotensin-aldosterone system, or RAS.
The RAS system is designed to raise blood pressure by forcing the kidneys to aggressively hoard sodium and water. The body retains massive amounts of fluid.
But because of the portal hypertension and the lack of albumin, all that newly retained water doesn't stay in the blood vessels. It leaks straight out into the peritoneal cavity, compounding the ascites. It is a vicious, self-feeding cycle. Patients can accumulate 10 to 20 liters of fluid in their abdomen, which crushes their lungs and limits their ability to breathe.
From fluid overload, we move to a neurological nightmare, hepatic encephalopathy. A healthy liver is the great detoxifier. When the bacteria in your gut digest proteins, they produce a highly toxic byproduct, ammonia. Normally, the blood carries this ammonia straight to the liver, where it is instantly converted into harmless urea and excreted by the kidneys.
But in liver failure, the hepatocytes are too damaged to make that conversion. Furthermore, remember those collateral varices we talked about? The blood from the gut is literally bypassing the liver entirely to get back to the heart.
Because it bypasses the liver, the massive load of ammonia goes straight into the systemic circulation. It travels to the brain, and ammonia easily crosses the blood-brain barrier.
Once inside the brain, ammonia is pure poison. It severely alters neurotransmitter balance, disrupts astrocyte cell function, and causes brain edema.
The clinical presentation is a complex neurologic syndrome. It starts with subtle changes in personality, memory loss, and irritability. It progresses to severe confusion, a characteristic flapping tremor of the hands called asterixis, and eventually the patient slips into a deep, often terminal, hepatic coma. Next, we have jaundice, or icterus. This is the yellow pigmentation of the skin and the whites of the eyes. Jaundice is simply the visible manifestation of hyperbilirubinemia, too much bilirubin in the blood.
Bilirubin is the yellow-green byproduct of breaking down old red blood cells. Normally, the liver grabs this bilirubin, conjugates it, meaning it makes it water-soluble, and excretes it into the bile to be dumped into the gut.
But when a patient turns yellow, my question is always, where exactly is the breakdown occurring? Because it's not always the liver's fault. We classify jaundice into 3 mechanisms.
Mechanism 1 is prehepatic or hematologic jaundice. The problem is occurring before the blood even reaches the liver. The liver itself is perfectly healthy, but the patient is experiencing a massive hemolytic event. Something is destroying their red blood cells at an incredible rate.
Like a severe mismatched blood transfusion or a sickle cell crisis. The liver is working at 100% capacity, but it is completely overwhelmed by the sheer volume of unconjugated bilirubin being dumped into the bloodstream. It can't process it fast enough, so the bilirubin backs up into the tissues.
Mechanism 2 is intrahepatic jaundice. This is when the liver cells themselves are damaged and failing. You see this in viral hepatitis or severe cirrhosis. The hepatocytes take up the bilirubin, but the cellular machinery is broken. They fail to conjugate it properly, or they fail to excrete it into the bile canaliculi. So the bilirubin leaks back out of the dying liver cells and into the blood.
Mechanism 3 is extrahepatic obstructive jaundice. This is a plumbing issue after the liver.
The liver is healthy. It is conjugating the bilirubin perfectly and pumping it into the bile ducts. But somewhere downstream, maybe a gallstone lodged in the common bile duct, or a tumor in the head of the pancreas, the pipe is completely blocked.
The conjugated bile has nowhere to go. It backs up through the duct system, engorges the liver, and eventually overflows directly back into the systemic circulation.
And a major hallmark of this extrahepatic block is the patient's stool. Normally, conjugated bilirubin passes into the gut where bacteria turn it brown, giving stool its normal color. If the duct is completely blocked, no bilirubin reaches the gut. The patient will produce chalky, light-colored, or clay-colored stools, while their urine becomes dark like cola because the kidneys are trying to filter the excess water-soluble bilirubin out of the blood.
The final systemic complication of liver failure is hepatorenal syndrome, or HRS. We talked about a GI bleed causing renal failure, but this is different. This is one of the most brutal examples of one failing organ deliberately taking down another. HRS is functional renal failure caused solely by advanced liver disease.
Let's go back to that massive splanchnic vasodilation. The liver is failing, it releases nitric oxide, and the arteries feeding the gut dilate massively.
So much blood pools in the gut that the effective circulating blood volume to the rest of the body drops to a dangerous low.
The kidneys are incredibly sensitive barometers. They sense this massive drop in systemic blood flow and assume the body is bleeding out. The kidneys respond by clamping down violently on their own afferent arterioles. They constrict their own blood supply, trying to maintain core blood pressure.
But the massive peripheral vasodilation is too strong. The blood isn't returning. So the kidneys just keep constricting until they starve themselves of oxygen. Renal perfusion drops to near zero. Glomerular filtration halts, and the patient experiences sudden, severe oliguria and acute kidney injury.
The tragedy of hepatorenal syndrome is that the kidneys are structurally perfect. There is no tissue damage initially. If you took the kidneys out of an HRS patient and transplanted them into a healthy person, they would function flawlessly. But the failing liver has chemically tricked them into shutting down.
Let's move to the specific disorders of the liver that cause all these systemic nightmares. We'll start with cirrhosis, which is the irreversible end-stage consequence of many chronic liver diseases.
Cirrhosis is an inflammatory, fibrotic disease that utterly disrupts the liver's architecture. The liver tissue turns into chaotic scar tissue. And to understand how this happens, we have to look at the cellular culprit, the hepatic stellate cell.
In a healthy liver, stellate cells are quiet, unassuming cells that sit in the space of Disi. Their main job is just storing vitamin A. They don't cause any trouble.
But when the liver suffers chronic injury, whether from decades of heavy alcohol metabolism, a chronic viral hepatitis infection, or severe fat toxicity, the immune system rushes in. Kupffer cells, the liver's resident macrophages, release massive amounts of inflammatory cytokines.
Those cytokines wash over the quiet stellate cells and fundamentally change them. The stellate cells undergo transdifferentiation. They lose their vitamin A, they change their shape, and they transform into aggressive fibrogenic myofibroblasts.
Once activated, these altered stellate cells start pumping out massive, relentless amounts of collagen. They lay down thick, chaotic, unyielding bands of fibrous scar tissue throughout the liver.
The liver tries to survive. The remaining healthy hepatocytes aggressively divide and regenerate, but they get trapped inside these thick walls of scar tissue. This forms hard spherical masses called regenerative nodules. The liver goes from a smooth, soft sponge to a hard, shrunken, cobblestone-like organ. That structural destruction is what causes the portal hypertension we discussed.
Let's look at the two most common pathways that trigger those stellate cells: alcoholic liver disease and non-alcoholic fatty liver disease, or NAFLD.
With alcohol, the damage is a direct chemical assault. The liver is responsible for metabolizing ethanol. But in doing so, it converts ethanol into a highly toxic intermediary compound called acetaldehyde.
Acetaldehyde is poison to the hepatocytes. It directly binds to cellular proteins, inhibiting their function. It alters vitamin and mineral metabolism. And crucial to the scarring process, the metabolism of alcohol generates massive amounts of reactive oxygen species, causing severe oxidative stress and lipid peroxidation, tearing the cell membranes apart. Years of this continuous chemical burn drive the stellate cells to scar the liver.
Now, non-alcoholic fatty liver disease, or NAFLD, and its aggressive inflammatory form, NAFL, is an entirely different mechanism. This is liver destruction in the absence of alcohol.
NAFLD is intrinsically linked to the modern metabolic crisis. It is heavily associated with obesity, metabolic syndrome, high cholesterol, and specifically severe insulin resistance.
Because the body is resistant to insulin, the normal storage of fats is disrupted. Massive amounts of free fatty acids are dumped into the blood. The liver takes them up and synthesizes them into triglycerides. But the liver can't export them fast enough, so the fat physically accumulates in droplets right inside the hepatocytes.
This severe fat infiltration causes cellular lipotoxicity. The engorged cells become stressed, they release cytokines, the immune system responds, and the stellate cells are activated once again, leading to fibrosis and cirrhosis, just like with alcohol, but driven entirely by metabolic dysfunction.
And once cirrhosis fully sets in, the systemic cascade is catastrophic. Let's just review the multi-system collapse.
Liver necrosis leads to decreased bilirubin metabolism, resulting in jaundice. The liver normally breaks down hormones, including estrogen and aldosterone. When it fails to do so, estrogen levels rise, causing men to develop gynecomastia, testicular atrophy, and spider angiomas on their skin. The failure to break down aldosterone worsens the sodium retention in ascites.
And the decreased protein synthesis means no albumin to hold fluid in the vessels and no clotting factors, leading to a massive bleeding risk.
Before we leave the liver, we must briefly touch on viral hepatitis. This is systemic viral-induced inflammation of the liver. We have a whole alphabet of viruses, A, B, C, D, and E.
The major distinction here is transmission and chronicity. Hepatitis A and hepatitis E are transmitted via the fecal-oral route contaminated food or water. They cause acute, often severe illness, but they very rarely become chronic. The body fights them off and you recover.
Hepatitis B, C, and D are transmitted via exposure to infected blood, bodily fluids, or sexual contact. And the terror of these viruses is that they are masters of evasion. They can evade the immune system and set up a chronic, silent infection that slowly drives inflammation and stellate cell activation for decades, leading directly to cirrhosis and hepatocellular carcinoma.
Regardless of which virus it is, an acute viral hepatitis infection generally follows 3 distinct clinical phases.
First is the prodromal phase. This begins about 2 weeks after exposure to the virus. It is characterized by insidious, vague symptoms, profound fatigue, anorexia, malaise, nausea, vomiting, and a low-grade fever. Crucially, the viral load in the blood and body fluids is peaking during this time, making the infection highly transmissible even before the patient knows it's the liver causing the problem.
Second is the icteric phase. Icteric means jaundice. This is the actual visible illness phase. The patient turns yellow, their urine turns dark from the bilirubin, and their liver becomes enlarged, smooth, and exquisitely tender to the touch. The severe GI symptoms from the prodromal phase might actually improve, but the fatigue worsens drastically.
Third is the recovery phase. The jaundice slowly resolves, the acute symptoms diminish, and liver function tests begin to normalize, though the liver might remain enlarged for weeks.
Let's move to our final major structural section, disorders of the gallbladder and pancreas. We will start with the gallbladder and cholelithiasis gallstones.
The formation of gallstones is primarily a story of supersaturation. The gallbladder's job is to store and concentrate the bile made by the liver. Bile is a delicate mixture of bile salts, bilirubin, and cholesterol.
If the liver pumps out an excessive amount of cholesterol, often linked to obesity, genetics, or high estrogen states, the bile becomes supersaturated. The bile salts can no longer keep all that cholesterol dissolved in the fluid.
The excess cholesterol begins to precipitate out, forming microscopic crystals. Over time, these crystals aggregate, stick together in the gallbladder, and grow into macroscopic hard cholesterol stones. These account for the vast majority of gallstones.
You can also get pigmented stones, which are black or brown. These aren't made of cholesterol. They are made of calcium bilirubinate. They often form in patients with chronic hemolytic diseases like sickle cell anemia, where the liver is dumping massive amounts of excess bilirubin into the bile.
Now, a patient can have a gallbladder full of stones and never know it. They sit quietly. The crisis occurs when the gallbladder forcefully contracts to squirt bile into the gut after a fatty meal, and it accidentally shoots a stone into the narrow cystic duct.
The stone acts like a cork. It wedges tight. The gallbladder keeps contracting against the blockage, causing severe colicky pain in the right upper quadrant. The trapped bile chemically irritates the gallbladder wall, causing severe acute inflammation known as cholecystitis.
But the danger escalates exponentially if that stone travels further down and lodges in the common bile duct right where the pancreatic duct joins it before emptying into the intestine. If that happens, we arrive at one of the most painful, devastating, and rapidly fatal conditions in the entire GI tract: acute pancreatitis.
I mentioned earlier that the pancreas is a factory. It produces incredibly powerful, highly corrosive digestive enzymes, trypsin, chymotrypsin, elastase. These enzymes are designed to rip meat and fat apart.
To prevent the factory from destroying itself, the pancreas produces these enzymes in an inactive, harmless precursor form called zymogens. They are packaged up and shipped out down the conveyor belt, the pancreatic duct, into the duodenum. Only once they safely arrive in the intestine are they chemically activated.
But what happens if the conveyor belt is blocked by that rogue gallstone? Or what happens if a toxic exposure, like chronic, heavy binge drinking, causes direct injury to the factory workers, the acinar cells themselves?
The cascade that follows is catastrophic. The blockage, or the toxic injury, disrupts the delicate intracellular transport. The zymogen granules fuse with lysosomes inside the cell. The enzymes become chemically activated intracellularly.
They wake up while they're still inside the pancreas.
It is literal violent autodigestion. Trypsin and elastase are proteolytic. They dissolve proteins. They begin chewing through the delicate pancreatic cells, dissolving the walls of the blood vessels, causing massive internal hemorrhage, severe edema, and widespread necrosis of the organ.
And lipase, the fat-digesting enzyme, is also activated. It leaks into the surrounding tissue and aggressively digests the mesenteric fat surrounding the pancreas, an incredibly painful process called fat necrosis.
And we return to our golden rule. A localized injury never stays localized for long. These incredibly caustic, boiling enzymes, along with a massive wave of inflammatory cytokines released by the dying tissue, do not stay confined to the retroperitoneal space. They dump straight into the systemic bloodstream.
Once in the blood, it's a systemic disaster. The inflammatory mediators cause massive systemic vasodilation and increased vascular permeability. Plasma leaks out of every capillary in the body. The patient crashes rapidly into hypovolemic shock.
The circulating enzymes and cytokines attack the alveolar membranes in the lungs, filling them with fluid and causing acute respiratory distress syndrome, or ARDS. They attack the kidneys, causing acute tubular necrosis. The autodigestion induces a massive systemic inflammatory response syndrome, or SIRS. It is the systemic shock, not the local pancreatic damage, that accounts for the high mortality rate in severe acute pancreatitis.
It is a devastating cascade. And if a patient survives multiple recurrent bouts of acute pancreatitis, or if they subject their pancreas to years of relentless toxic injury from severe alcohol abuse, they develop chronic pancreatitis.
In chronic pancreatitis, the relentless cycles of inflammation and necrosis activate pancreatic stellate cells, very similar to the mechanism in liver cirrhosis. These activated stellate cells lay down dense, permanent, fibrous scar tissue.
The soft, glandular tissue of the pancreas is irreversibly destroyed and replaced by hard strictures, massive calcifications, and cysts. The organ simply turns to stone.
The clinical result is a life of chronic, intractable, debilitating abdominal pain that is notoriously difficult to manage, often requiring high-dose opioids. Furthermore, because the exocrine factory is completely destroyed, the patient suffers severe malabsorption, steatorrhea, and profound weight loss.
And because the fibrosis eventually destroys the islets of Langerhans, the endocrine cells that make insulin, the patient almost universally develops insulin-dependent diabetes. The pancreas is gone.
We have traced the pathophysiology from the mouth to the accessory organs. We must briefly address the final section, cancer of the digestive system.
Looking over the data for GI malignancies, there is a massive, glaring, recurring theme that ties all of these specific cancers together. It isn't just bad genetic luck. The soil in which gastrointestinal cancer grows is chronic, relentless inflammation.
It is a direct, observable biological line. The chronic acid reflux and mucosal burning of GRD leads to metaplastic changes known as Barrett's esophagus, which is a direct precursor to esophageal adenocarcinoma.
The decades-long chronic inflammation, cytokine storms, and tissue destruction caused by H. pylori infection is a direct primary risk factor for gastric cancer.
The relentless autoimmune plaque and mucosal regeneration seen in inflammatory bowel disease vastly increases the risk of colorectal cancer.
The fibrotic scarring and chaotic cellular regeneration of cirrhosis is the leading precursor to hepatocellular carcinoma. And the chronic scarring of the pancreas paves the way for pancreatic adenocarcinoma.
It all comes back to the fundamental cellular level. Constant tissue injury forces the body into constant, rapid cellular regeneration to try and heal the breach. Constant, rapid division in an incredibly toxic, highly inflammatory environment massively increases the risk of DNA replication errors, mutations, and eventually uncontrolled malignancy. Inflammation is the driver.
We have covered an immense amount of ground today. We have traced the cascades of shock, the mechanisms of obstruction, the autoimmune destruction of the gut wall, and the multi-organ collapse triggered by the liver and the pancreas.
And I want to leave you with a final thought to mull over as you organize this material in your mind. We tend to think of the gastrointestinal system as just a plumbing pipe passing through our body, but it isn't. It is an incredibly sophisticated, highly communicative, and vastly sensitive barrier separating the dangerous bacteria-filled outside world from your sterile internal environment.
Every single altered function we discussed today, from a single NSAID pill blocking a prostaglandin and triggering a massive bleeding ulcer, to a failing liver chemically tricking the kidneys into shutting down, demonstrates the core truth of advanced pathophysiology. A localized injury is an illusion. The body is an intricately unified system. When one domino falls in the gut, the entire systemic cascade follows.
Master those cascades, understand why the cell fails, and you will understand exactly what is happening to the patient in front of you.
On behalf of the Last Minute Lecture team, thank you for sticking with us through this intensive deep dive into the digestive system. We wish you the absolute best of luck in mastering your advanced pathophysiology exams. You've got this. Take a breath, trust the physiological logic, and we'll see you next time.